Hello, everyone. My name is Frank Placencia. I am a neonatologist and an ethicist at Texas Children's Hospital and Baylor College of Medicine in Houston, Texas. I want to thank you guys so much for inviting me to talk here at the non-virtual annual conference. My topic today is ethical considerations at the edge of viability. Perspective is everything. So I'd like to dedicate my session to Grayson Harris. Now, Grayson and his twin brother Griffin were born at 23 weeks. They were one of the first sets of patients that I ever cared for as an attending. Unfortunately, after repeated bouts of meningitis, Griffin's parents made the very difficult decision to withdraw life-sustaining therapy for Griffin. Now, Grayson unfortunately also suffered some of the complications of prematurity, including BPD and ROP. But thankfully, he was able to overcome them. And now he's in middle school. And as you can see here, he is just a phenomenal baseball player, just like his mother was a phenomenal softball player. All right, so disclosures. Unfortunately, I have nothing to disclose. Not a big deal, though. As an ethicist, it's probably best to keep my hands clean. So, just a brief outline. We're initially going to discuss various ethics frameworks and how we go about trying to be good physicians and healthcare professionals, as well as how to make difficult decisions. We're going to talk a great deal about context and its effects on our understanding of objectivity and subjectivity. Then finally, we're going to discuss some special considerations at the end of life. All right, so what is ethics? I think most of us think of it generally as a moral code, sort of rules to live by. Others, I think of it as guidelines for helping us know what is a right or wrong action. But ethics really should be looked at as, how do we live in a society? How should we act as people to live in a society so that society functions well? Now, this is a little Lego Hamlet, and although this is not what Shakespeare meant, I think the idea of to be or not to be is very important here. What does it mean to be a good person? Well, that is the basis of professionalism. A good healthcare professional is one who does what the ideal healthcare professional would do. Now, of course, that is a somewhat circular argument, but it is the basis of how we look at ethics for some time now. Now, a good professional will exhibit traditional medical virtues. Some of those virtues include fidelity, the idea of faithfulness to your patients, effacement of self-interest. What that means is putting your patient's interests first before your own. And I think that sounds very familiar. Compassion and caring. Now, I shouldn't need to tell a group of nurses the importance of caring and how central it is to medical ethics. Intellectual honesty, both being honest with your patient, but also honest with yourself about what you don't know. And finally, prudence, not making rash decisions and trying to be calm and deliberate about the decisions you make. Now, this slide here is the American Nursing Association's Code of Nursing Ethics. And you can see a lot of those virtues that we mentioned on the previous page can be found here as well. So you notice compassion, commitment, responsibility, integrity, collaboration. Those are all also core to nursing ethics. Now that's about how one should be, but as Batman would say, it's not who you are underneath, but what you do that defines you. So if virtue ethics focuses on what kind of healthcare professional we want to be, then what is it that we should do? Well, you guys are vaguely familiar with the four principles. And so let's go through them briefly. So the first one is beneficence. Now, beneficence is putting your patient before yourself, right? It's that effacement of self-interest I talked about earlier. Now that seems, pretty obvious, but to use an example, pharmaceutical companies used to spend incredible amounts of money, and honestly still do, to try to convince, especially physicians, to prescribe their medications. Now, these pharmaceutical companies have access to the best marketing companies out there, and they do very good cost benefit analysis. So if it didn't work, they wouldn't do it. As an example, when I was a medical student, I did a rotation with a family practice doctor had a very busy clinic in downtown Houston. And I was there for Valentine's Day. And I was floored at the gifts that she would receive from these pharmaceutical companies. $100 bottles of wine, tickets to the opera, to Rockets games. It was just unending. During that month, I never once had to bring a lunch because every day lunch was prepared. Now, again, these pharmaceutical companies, these drug reps, they knew what the effect of their gifts had. And so clearly, accepting those gifts risked violating this principle of beneficence. And we have non-maleficence. Now, most of you may think of that as, first to no harm. But again, I'm speaking to a large group of nurses here. You guys have put in many IVs. Well, the very first thing you do is cause harm. So non-maleficence is a little more complicated than that. We should think of it as, on average, do more good than harm, right? And so that's going to be very evidence-based. That's going to help you make good decisions and feel reassured that the actions you are taking in the long run are more likely to benefit the patient than harm them. Then we have justice. And I know I said I was going to briefly go over these four principles, but I think that it's worth getting into justice a little deeper, especially with everything that's going on right now in the news. So when we think of justice, we traditionally think of distributive justice. How do we allocate resources? And that's certainly a very important part of justice. But justice is more than that. At its core, justice is treating individuals similarly unless there is a morally relevant difference that justifies treating them differently. Now, that seems straightforward, but let's be honest, that definition is a little bit loosey-goosey, right? It allows for some subjectivity. For example, not that long ago in this country, the color of your skin was a morally relevant reason to treat you differently. Now, I'd like to think we'd moved beyond that, but recent publications looking at how neonatologists treat patients differently based on race is very disheartening. And of course, there are other factors that come into consideration. Certainly religion is sometimes given as a reason to treat people differently. Your immigration status. We've had to deal with issues related to immigration status and transplant candidates at Texas Children's Hospital. So that's justice at its core. But another branch of justice that I think is worth talking about is social justice. And this is a word that gets thrown around a lot in the media, especially right now. But what social justice is saying, or the core of social justice, is that the idea that society is organized in a way that is sometimes unfair. And structural racism or social injustice doesn't require that anybody be racist or act in an intentionally racist manner. It's just going to, due to structural, the ways society is organized, it is going to result in unequal outcomes. So I'm going to give you an example. This is a map of Houston, where I live. And it's part of the Dot Map project. And the people who created it basically took census data and assigned a color to whatever race a person said they were. And so blue dots are white folks. Green dots are African Americans. Orange dots are Hispanics. And red dots are Asian Americans. Certainly there are many mixed folks that aren't necessarily shown here or given another color altogether. But generally, one thing that comes out to you is just how segregated Houston is. And I especially want you to pay attention to the areas in the Northwest, near the areas of Tomball, the Woodlands, and in the middle and west sides of town, Cinco Ranch, Bunker Hill Village. Okay, so this is where folks live. Now, Texas Children's Hospital, where I work, has opened up or purchased a large number of pediatric clinics throughout Houston. The reason they did this was to ensure that they got the referrals from those clinics to our hospital. And when they made the decision as to where to open these clinics, Texas Children's Hospital is a business. And so they wanted to make sure that the patient population had a very high likelihood of having private insurance, because they felt that that was more likely to result in increased revenues. And so they focused on opening up clinics in areas of town that had high percentages of private insurance. And so here is the map of where we have our clinics. Now I'm going to toggle back and forth so you can see that this very closely aligns with where the white folks live in town. Right? You can see in the upper northwest corner that a lot of the clinics are in white neighborhoods, and in the area just north of downtown, there's a pretty large gap where mostly African Americans and Hispanic patients live. And then you have a couple of outliers on the edges of town, which tend to be, for the most part, where we have our white neighborhoods. And so what I'm trying to say is not that the folks who made this decision were inherently racist. I don't believe that they intentionally meant to discriminate against African American and Hispanic individuals. I'm not saying that at all. What I'm saying is they made a decision based on finances, because in our society, medicine is structured as a commodity. It is something that is purchased and then consumed. And because society is structured in that way, they made the smart business decision to focus on areas of town where they were likely to get better revenues, to generate greater revenues. The result of that was racist. So that's structural racism, right? Structural racism doesn't require that a single racist be involved. All it means is that we ignore how structural systems in society lead to discriminant outcomes. All right. So finally then, respect for autonomy. So respect for autonomy is the idea that we should respect people's wishes because they are rational human beings. They know generally what's best for them, and to violate that autonomy seems to be a moral wrong. Now the problem, of course, is we're talking about neonatology. And so unless you're dealing with boss baby, our patients aren't rational, right? They're not autonomous. And we rely on their parents to make choices. The question then becomes, are there any constraints on the choices that their parents can make? And yes, and we generally think of that constraint as the best interest standard. And so let's talk about that a little bit. So when we're making decisions, to whom is our ultimate moral responsibility? Is it to support the parents' parental autonomy and their decision-making authority, or is it to protect the best interests of our pediatric patient? And honestly, that's, I think, pretty straightforward. I think all of us know that it's to protect the best interests of our pediatric patient, and that's why the best interest standard is a restraint on parental autonomy. So, but let's dig a little deeper into the best interest standard. I think a lot of folks, when they think of best interest, they're thinking of interest as effects, like what's best for the baby, what's going to give the baby the best outcome. But I would argue that there's a problem with that definition. I think interests are more global than that. For example, the example I like to use, I work a lot of hours. I don't get to sleep much. And so it's certainly in my best for me. It's certainly best for me to sleep in on the weekends. But I have an interest in making sure that my children are well fed and have a good breakfast. And so it's in my best interest to get my butt up on Saturday morning and make sure they get to eat, right? And that's the difference between effects and interest. And I think that sometimes that distinction gets lost. But also, whose interests need to be considered? As I just referenced, sometimes we forget that it can be really hard to separate the interests of a child or a parent from the rest of the family, right? We're not truly discrete individuals. Our interests intermesh, and it can be really hard to separate them out. Who decides what are an infant's interests? I think we tend to, let me take a step back. As healthcare providers, we are experts in the medical field. And we are certainly the experts on a child's medical interests. But we are not experts on the global interest or the holistic interests of the child or the parent. And so the best interest standard is traditionally been used to guide decision-making for children, but some folks have proposed a sort of a corollary principle, which is referred to as the harm principle. Now, this is basically when should we intervene to counter the parent's wishes. And basically it's when we are convinced, not feel, that's too soft a word, when we are convinced that these parents are objectively harming their child. And I use that word objective there because there are some problems, unfortunately, with that word. And we're going to get into that in just a little bit. Now, there's another paradigm that I think is worth discussing, and it's the relational potential standard. And the way this concept works is that our children in the NICU, unfortunately, many of them are going to have difficult lives. Their neurodevelopmental outcomes are not going to be optimal for many of them. And so it can be useful to rethink what we consider to be an acceptable life for them. And in a relational potential standard, the goal is to focus on the potential for the child to develop some sort of relationship with their caregiver. So the potential for that relationship is central. Once the child has lost that potential, then redirection of care becomes paramount. Now, What are some of the challenges and limitations with a relational potential standard? Well, it requires that we have better prognostic tools than we often have in the NICU, right? That's going to be a long-standing problem in the NICU. And understanding what is a relationship, or what is a valuable relationship, can be a little bit challenging for those of us who are not in that relationship, right? We may judge it differently than the parent does. Okay, so how do we make decisions? Well, in the past, we tended to use a paternalistic approach, right? The physician or the medical team would say, this is what we're going to do, and we expected that the family would accept it. Then we sort of swung the other way, right? As respect for autonomy really gained strength, we moved towards sort of an informed or a menu approach, where basically the medical team would, tell the family all the information they thought was important, and basically said, hey, here are the options, you choose. And sometimes we would fail to give a recommendation, which I think was really hard for families. What's generally considered to be the appropriate approach now is the shared or collaborative model, where what you're striving for is a free flow of information between the medical team and the family. And eventually, as you share the information, you can tweak your recommendations until you reach an equilibrium where both the medical team and the family can agree upon what the right decision should be. All right, we're going to take a pause for a little bit, and we're going to get into context. So we're going to look at some interesting kind of trippy pictures here, but just bear with me. So this is an object here, and it's rotating. The question is, what direction is it rotating? Is it rotating horizontally around that green cylinder? Or is it rotating vertically along this red cylinder? And the answer is it is entirely dependent on your perspective. Here's another example you guys are probably familiar with, especially if you spend any time on social media. This is the infamous dress, right? That some folks swear up and down is blue and black, and others believe is gold and white. Now, I like this picture because of the effect it had on me. When I initially saw this picture pop up on my Facebook feed, I saw it as gold and white, and I wasn't really interested in it, so I didn't really read it until it became so sort of omnipresent that I said, okay, I got to figure out what's going on here. And so I read the story, and then I remember I got to the line with it where it said, oh, some folks swear that it's black and blue. And I said, what are they talking about? It's clearly gold and white. And I went back to the picture, and lo and behold, now I saw it as black and blue. And in fact, it has remained black and blue for me since then. What it made me realize, though, was that for me, for my reality was that this dress was white and gold, right? That was, as far as I was concerned, an objective truth for me. And the fact that it changed on me made me realize that maybe not every truth that I am so certain about is really objective. Here's another example. Now, these are a bunch of hearts. You can see them. And I think for most of us would agree that the hearts look green and blue. The green ones have some little orange stripes in them. The blue ones have some little pink stripes in them, but that's basically the color. Right? And I'm going to zoom in here. Same thing, right? One green heart, one blue heart. The green heart has some orange stripes, and the blue heart has some pink stripes. But what if I covered up those stripes that go through the hearts? Now they're sort of teal. So was the heart teal to begin with? Well, it seems here we have uncovered an objective truth, right? They were teal to begin with, But the problem was there were other variables, the orange stripes on the left or the pink stripes on the right, that were making us think we were seeing something different than it was. Similarly, you guys are probably familiar with this picture. It's the idea of, if you took 5 people with blindfolds on and brought them to different areas of an elephant, how would they describe it? Right? The gentleman on top of the ladder there would swear that he basically was hugging a huge warm rock. Right? The lady in the back with the tail, that the essence of an elephant is a snake. It's like a snake with a fuzzy head. The gentleman in the middle holding the leg would say, no, an elephant is like a tree, right? It's like a tree trunk. The gentleman holding the elephant's ear would say, no, an elephant is like a huge sail, like a fan, right? And I'm not even going to have no clue how the lady would describe the elephant's trunk. But you can see that even though everyone here is describing an elephant, from their perspective, what they're describing is incredibly different. The essence of what an elephant is, they're not even compatible, or at least so it seems, from their limited perspectives. And so here's another example of an elephant here, and this is a piece of art. They're going to rotate it. And now we see 2 giraffes. So is the art installation an elephant? Or is it a giraffe? Is it both? Is it neither? Right? Depending on where you're standing, depending on your perspective, your context, the reality of what you're seeing is different. So what does this make us think about, right? I talked earlier about, the harm principle. We should use that to intervene when we believe that the parents are the decision the parents are making is objectively harming the infant. Well, we need to be really certain that that is the case before we actually intervene, because as these examples I just showed you, it's not always clear what is objective truth and what is not. In reality, much of life is subjective. And so when we go to counsel families about either resuscitation of children at the edge of viability, or we have end-of-life discussions, we need to have a little humility and understand that the objective truths that we believe to be absolutely true, they may be true. Like the teal hearts, we may actually be seeing teal, but we have to understand that the families may be seeing a totally different color, right? And therefore have difficulty understanding where we're coming from. So we have to ask ourselves, what is our context? Where are we coming from? We have to understand that there is a problem with evidence-based medicine. Although I do believe we need to base our decisions on the best evidence available, we have to understand that there are fundamental problems with that evidence. For example, when we talk about measuring the outcomes for our patients in the NICU, when should we measure that outcome? Should we measure it at 1 month, 2 months, 2 years, 10 years, 20 years? Well, I mean, honestly, the best outcome is later in life. So let's say we say 10 or 15 years. That's we should measure the outcomes of an intervention 15 years out. Well, the problem with that is that medicine changes a lot in 15 years. I mean, let's think about the changes we've seen in our lifetime, the use um, of special lipids that avoid TPN cholestasis, the increased use of donor breast milk, uh, all those things have a definitive impact on the outcome of our children. But, you know, we need to realize that, therefore, the outcome data we're looking at probably underestimates the likelihood of a good outcome for the children that for the current pregnancies that are in gestation. There's also a problem with experiential bias, and that's where I want to um, discuss my patient, Grayson and Griffin, that I talked about earlier. But before that, let's get into some more slides. There's also a bias towards the abled, and one of the actually, before I go forth, let's go to the next slide. So let me tell you a story that I learned early on in medicine. So it's the Rome Amsterdam story, and I'm sure some of you may have heard it, but bear with me. So, Rome is a very popular destination for tourists, right? Lots of people have dreams of going to Rome and going to see the Roman Forum, the Colosseum, or the Trevi Fountain. And, imagine a family that has planned their whole life to do this. But unfortunately, their plane gets stuck, and they end up having to spend their vacation in Amsterdam. Now, they weren't planning to spend their vacation in Amsterdam. They weren't excited about eating Dutch food or hanging out in in the countryside of the Netherlands. But even though that wasn't their plan, they kind of enjoyed it. They enjoyed the canals of Amsterdam. They enjoyed the red light district, which we won't show them what they enjoyed. Or perhaps they enjoyed the Rijksmuseum. The idea here is that bias towards the abled, all of us in medicine are high achievers. We have certain expectations for ourselves, and let's be honest, we have those expectations for our children as well. Well, when we carry those expectations, those are a form of bias, right? We have a bias towards the high functioning child. And so when we try to explain to a family, well, your child has Down syndrome or trisomy 18, or they're have severe prematurity and they've suffered a horrible IVH, we're mourning the loss of Rome. In my interviews with families, what I have learned is, for many of them, though not all of them, they really enjoyed the trip to Amsterdam. And maybe it wasn't what they were planning, but they wouldn't have traded those experiences for the world. And so what is all this? What are the implications of this for counseling? Well, one, it's important to have guidelines, right? You want to be able to refer to guidelines that your section, your hospital can all agree to. And this is hopefully to ensure that you treat similarly situated patients similarly. And therefore you're acting justly, but also don't forget that structural injustices can play a part and need to be accounted for. We need to listen to our families, right? We need to understand what their goals and desires are, what they're understanding. I think oftentimes when we meet with families, and they don't agree with what the counseling that we're recommending to them, people often say, well, they just don't get it. In my interviews with these families, I have found that oftentimes they don't get it. They're just holding on to hope, and when we keep sort of browbeating them with the negative information, at some point they don't want to hear it anymore. after listening to them, we then need to tailor our recommendations to the goals that they have as much as possible. And then, depending on how the child reacts to the plan that we put in place, we need to revisit these discussions. And I think that's one of the biggest challenges. Many of my colleagues are not afraid to have that initial discussion with the family. Maybe we should redirect care, or maybe we should limit our interventions. And depending on if the family says no, we want to go full court press, at that point, they just say, okay, well, that's fine. This family just wants to do everything. And they're afraid to revisit the discussion and take advantage of the fact that new experiences may affect how families see, or how it affects how they look at their goals. All right, so let's take a little dance break. Sorry, I just really like this, Jeff. It makes me laugh. All right, so a little bit of history of neonatal ethics. So who was Baby Doe? Was it Bambi's sister? Was it John and Jane Doe's little bundle of joy? Or was it the patient whose case was most responsible for modernizing neonatal ethics? You don't get any extra points for getting this answer correct. All right, so a little bit about Baby Doe. So in 1982, Baby Doe was born in Indiana with Down syndrome and a tracheoesophageal fistula. Now, the physicians could not agree on a plan. Some of the physicians said that, well, this child has Down syndrome and a TE fistula. The best thing we can do, the most compassionate thing we can do, is to do nothing and allow the child to die from their condition. Other physicians said, you know what, no, there's actual surgical treatments we can do for this, and we should do it. So what's clear is that some of the physicians didn't fully understand the options for this condition. But the parents, they were making a rational choice, right? They had two sets of physicians making what seemed like reasonable recommendations, and the parents elected comfort care. Now, the hospital, unfortunately, was very uncomfortable with this situation, and they sued to transfer the infant to another hospital. The court that heard the lawsuit, however, said no, the parents have chosen a reasonable option that was presented to them. The hospital was not comfortable with that decision, and so they appealed up the chain and all the way to this U.S. Supreme Court. Unfortunately, the baby died before the Supreme Court could hear the case. Now, a little context. Who was the president of the United States in 1982? When Baby Doe was born? Well, that was Ronald Reagan. And we can all remember him because he was the champion of the Right to Life movement. Who was his Surgeon General? I don't actually expect for those of you to know, but it was Dr. C. Everett Koop. Now, what was Dr. Koop's specialty? Well, he was a pediatric surgeon with extensive experience repairing tracheoesophageal fistulas. So it should come to us as no surprise that the Reagan administration, led by Dr. Koop, felt that this situation was untenable, right? That they were letting children with Down syndrome die from an easily correctable surgical condition. And so, without getting into too much of the detail, eventually they codified into law a change in the definition of child abuse. And what they said is that child abuse includes failing to provide medically indicated treatment for life-threatening conditions, except for extreme circumstances. And so what this led to was a lot of concern about when is it okay to stop life-sustaining therapy if, conditions like trisomy 21 or, we now have to operate on them. When is it okay? Well, what we learned is that we need to be very evidence-based and when we make our decisions as to which children should have LST stopped, and whatever procedure we use needs to be methodical and rigorous. And so we have, in fact, tried to come up with some tools to help us um, make those decisions, especially at the edge of viability. The AAP and the NRP have each put out their guidelines suggesting that at less than 22 weeks, we probably should not be resuscitating infants. But above 22 weeks, it's really up to the family, up until about 24 weeks when resuscitation should be mandatory. We have the NICD calculator, which is a nifty tool where you can put in these 5 factors, including gestational age, sex of the baby, birth weight, antenatal steroids, and whether it's a singleton or a multiple. And that will give you a predictor of the likelihood of survival or survival with good neurological outcomes. Truth be told, the best indicator is your institutional inborn data, right? How does your particular institution deal with premature babies? The challenge, of course, with that approach is that oftentimes, especially at the infants at the edge of viability, your 22, 23 weekers, you oftentimes do not have enough patients to make that data robust enough to make a prediction. And that's a real challenge. So the best approach is generally to counsel families using the best available data. You want to be consistent in your approach. And if you're going to do a trial of intervention, understand that it's a trial, right? You're going to see if your interventions achieve your goal. And if they don't, then we need to revisit the discussion about, what is the best thing we should do for your infant. Now, when should we consider foregoing life-sustaining treatment? Well, the AAP suggests that when early death is very likely and survival would be accompanied by a high risk of unacceptably severe morbidity, then foregoing intensive care is the right thing to do. However, when the prognosis is uncertain but likely to be poor, and the survival may be associated with a diminished quality of life, then the parental desires should determine the treatment approach. And I think that this is a pretty solid approach to decision making. So let's talk a little bit about artificial nutrition and hydration. Now, the AAP says it is ethically supportable to forego artificial nutrition and hydration when there is consensus that they do not provide that benefit. In my experience, it can be very helpful to get the hospice or palliative medicine team involved. What we have found is that their willingness to be aggressive in fluid restriction has actually resulted in the infants in question living much longer than they would have, because we were afraid to restrict their fluids as much as they were. And their help can be very beneficial. Now, it's not always going to prolong their life, but it very well may minimize the suffering that the children are going through by removing some of the respiratory distress associated with the dying process. So a few takeaways here. The best interest standard trumps parental autonomy. However, we need to remember context, that our understanding of when parents have gone too far is often tainted by our perspective, and it requires a great deal of humility to take that step. The relational potential standard, where we focus on the baby's ability to form a relationship, may be a better approach than, say, a quality of life approach. The recommendations we give the parents should reflect the parental goals. So that means that we must be willing to engage in a series of discussions with families about their goals and values and what they want to do for their infant. Resuscitation should be site-specific. Ideally, it should reflect your experiences at your institution, but again, context matters. If you do not have a lot of experience with the most immature infants, you may not be able to really trust the data that you have. And finally, that trials of intervention are just that. They are trials, and we need to be prepared to go back and rethink what our plan of action is. And so I promised you guys a little bit of discussion on Grayson and Griffin. The reason they stuck with me so much is that, and why I think this sums up why context is so important, is that, had Griffin survived, he would have been a child who was neurologically devastated. And I would have seen him, let's say I was a pediatric resident, he's one of those patients who would have been a frequent flyer in the ICU. And, we know how those children end up, and we know how much suffering goes on both for the child and for the family. And had that been my only experience, I would have thought to myself, 23-weekers just don't do well. We really shouldn't be resuscitating them. But, he had a twin. And I've been so fortunate to see Grayson grow up. And that has really impacted the way I look at premature infants, realizing that, we are exposed to the worst of the worst, and therefore we often predict the worst. And we need to hear these stories and to understand why sometimes parents hold on to hope, and sometimes that might be the right thing. Well, guys, thank you very much for listening to my speech. I hope it was helpful, and goodbye.